Hi, good afternoon. Welcome.
Hello.
Afternoon.
Hi, everyone.
Hello.
Hello.
Hi, this is Emma with EMI.
Hi, Emma.
Hey.
Folks are dialing in. Hi. Welcome, Beth. Rachel, happy first day.
Thank you so much.
Thanks for joining and prioritizing our call. I really appreciate it.
My pleasure. Thank you.
All right, I think we can go ahead and get started. So we streamlined the agenda a little bit. So we'll just, we have a little bit of housekeeping that we think will just be helpful moving forward. And then we've combined the two agenda items of walking through the initial list of long COVID symptoms list, as well as with the agenda item of walking through the data element gathering spreadsheet, because the symptoms list is in the spreadsheet. And so it'll just be helpful to kind of talk through all of that together. And then in terms of next steps, so as was written in my email last week, we will be asking folks on this call to provide data elements specifically around the broad area of health concerns for long COVID following today's call, and that'll be open for around 3 weeks. And then our team will synthesize that information and come back in our March meeting to debrief and open the next round of data element collection for the next topic. And we are going to just make 2 options available for submitting data elements, just to, because we know you all are very busy, so we want to make this as easy as possible. So one option will be reviewing from the spreadsheet, and then the second option will be simply to forward us whatever documentation in whatever form it's in for any data elements for long COVID that you want to submit for consideration. And so just some quick housekeeping, the live transcription is available. And then we also would like to request that folks, if you want to contribute feedback, there will be a time when we review the symptoms list for everyone to kind of weigh in on that initial list. And so to encourage balanced participation, we will ask folks to just use the hand raise feature. If anyone is unclear on how to do that, it should be in the toolbar for your Zoom meeting, and there is a way to use, yeah, you should be able to find it in the list of the hand raise feature. And so we just ask that you wait until a facilitator calls on you before speaking. And then as always, you can use the chat to type in any kind of feedback that you want to make sure is captured. We do review all of the chat messages when we put together the meeting summary. So that is that's a great way to collect feedback. And then just in general, like be mindful to allow for folks who haven't gotten a chance to speak so that we're capturing a comprehensive representation of all the different types of expertise on this TEP. Any questions? All right. So we will dive right in. So based on our brainstorm list from the January meeting, Emma and Gay, our nurse informaticists, standards terminology SMEs, have put together an initial list of long COVID symptoms data elements. So we will reserve some time later on in this call to go through this list and comment, but you can see a screenshot of the high-level symptoms that we've identified from there. And before we get to that, I would like to turn it over to Evelyn to just provide some context and framework for what are the data elements we're looking for and how we would like to request your input on those.
Great, thank you, Karen, and good afternoon, everyone. So I believe I'm assuming, but I will check my assumptions. If not, we had shared this initially in past presentations and when we kicked off the initial TEP, really setting the context around care planning. So for those not familiar, the visual on the left-hand side comes from the HL7 Patient Care Work Group Care Plan Domain Analysis Model, which I feel does a very nice job of articulating all the inputs and activities that are part of the care and outputs of the care planning process, and really incorporates, what we're doing right now is those inputs is acknowledging that it includes information about the patient, the individual, that moves beyond clinical care. So it has health history, SDOH, labs and vitals, and functional capabilities. And then we go through the process where we talk about that as part of the clinical workflow, which is assessment, diagnoses, goals planning, execution, identification of interventions to act on the the goals identified by the patient and their provider, and then the ability to measure the outcome. So that you see all of that putting together in the care plan domain analysis model. What you see on the right-hand side, for those not familiar, is the conceptual framework developed by the Gravity Project to sort of put this into context of where SDOH data fits in. Again, you see the similar clinical workflow activities of screening or assessment, diagnoses, which includes the incorporation of the health concerns, the observations, problem list, setting goals, and then the actions on, the interventions to address that, and acknowledging that there are different care team members throughout the process, and ultimately users of the data extend beyond the clinical care team and the community-based or interdisciplinary care team. You also use the data, researchers, researchers use it, social services, payers, and what's missing there is public health, but acknowledging that the data can be, because it's standardized, it's available for upstream and downstream use. Next slide. So then we took it so when we started looking, so this comes from the care plan, the Gravity Project, when we first introduced to our large collaborative, breaking this down into data concepts and really defining what we mean by data element for the care planning process. So this is just a different view, but then it brings in what we will talk about when we think of those data element components or areas, is breaking them down into health status evaluations and outcomes, right? Those things that need to happen that are ongoing. You're evaluating the patient, the person, you're making you have an observation, you have a diagnosis, you define the health concern, and then you create a plan around it, right? So these are all the things that you'll see as we think of grouping the components of a care plan, and as well as aligning it to the clinical workflow and processes. Next slide. So it brings us to the care planning framework, or the components. And we've been working on care plan standards for many years. And, again, this is very similar, breaking it up, what you see in the previous slide here. And this ties in how then we define data concepts, right? We have to put them in, define them based on the component that they fall under. So when we dive into the data elements, as Emma will spend more time on, is really around these groupings of health concerns that are derived from the assessment, screening, symptoms, what you saw on the previous slide, the goals that include the patient and caregiver goals, and they're the center of decision making. So you determine based on those goals what activities or interventions or treatment you will have. And then lastly, very important, is measuring. You have milestones and indicators, but you really want to evaluate whether the intervention identified is meeting the goal identified. Next slide. So data breakdown. And I think there's an overlap here. So when we talk about data element, there's definitions. So we are building it off. I think these are from NIH. A data element is a concept that has been defined specifically. When it is coded concept, the definition uses a value set to describe the range of concepts relevant to the definition. So from a date, you start with the data element, and then it has the value set, and there is value set groupings. A value set is defined, contains a set of coded concepts that are subset of codes from a code system. And by code system, we look across open code systems, LOINC, SNOMED CT, ICD-10. We also have proprietary, we have CPT and HCPCS, but they are all code systems. So that's what we look at when we say the value set is a grouping of these for a specific data element. And the code system is defined there. So it's really important to just look at the sequence of this. So when we do a deeper dive into what Emma will show you is what we mean by data element, and then how those eventually will need to, once they're all coded, they are grouped into these value set groupings. Here is the definition again up front, data element definition. Is information that describes a piece or unit of data. The data element definition is not the data, it is the data about the data. So that's really important. So this is just a snapshot of data elements within the resource content content resource. So it defines, as you see here, the data element for status, right? And there is a grouping, you know, it talks status is defined as either planned, arrived, triaged, in progress. So really this is what, when you think of a data element on a card or in a field, you know, you're all familiar with that. Is like you have to enter information in it. And so this creates a structure around how you know what information needs to go within that specific field. Next slide. And here is another snapshot, but then it brings into where you all come in as the technical expert panel for this. So here is how we envision breaking up health concerns. And we think of it as data element categories and then the actual data element. So symptoms is a great example. Let's just use that one for now. Symptoms is a category and it's broken up into 3 data elements: fatigue, brain fog, pain, right? And then from a coded perspective, it aligns with the FHIR construct of value set. So all of this is part of the MC. And then, you know, from an implementation guide perspective, it just defines how and where and when you use these, right? So we'll go through this in more detail, but it's just to create a hierarchy of how this information needs to be captured. And it's really, when I'm looking at learning myself about terminologies, taxonomies, and ontologies, is really creating a library system of index of how we organize this information. So as we can, you know, it becomes machine readable, right? So and that you all understand even from an end user what needs to go there. And then we use the code so that the system itself also, there is no ambiguity on what the concept means. And I'll pause there before I jump in if there's any questions, or and Emma wants to chime in.
I was wondering how the data elements like fatigue, brain fog, and pain are graded. Are they just yes or no, or is there some sort of severity scale you propose?
Yeah, so thanks for your question, Henry. So that will come into play in the next, later on, because for the actual list, we've actually associated assessment scales with some symptoms that have assessment scales.
Mm-hmm.
And to answer your question, yes, you can apply things like severity and, you know, all of that. Capture that information, you know, at the point of data collection. There's a way to get it out and put it into the FHIR structure so that it is shared. Severity, status, you know, there's lots of attributes that can go on a particular piece of data along with a particular piece of data.
Are there any other questions, or Henry, does that answer your question?
Yes, thank you.
So Beth asks, can standardized questionnaire be for these symptoms be used? And Emma, I believe the answer is yes.
Yes, the answer to that is yes. And, but remember, you can use it in your system, and then what Gay and I will, you identify, you let us know what it is, and we will spend a lot of time trying to figure out how to fit it into the FHIR spec, you know, so that you could exchange this information.
All right. Yeah. So I think these questions all kind of highlight exactly what we're looking for from the TEP in terms of data elements. So we would love for you to surface these kinds of questions and provide information on the data elements and information around what is required to make those usable. And then Emma and Gay will figure out how to get it to work. So in terms of submitting data elements, as I mentioned earlier, we'll have the data element gathering spreadsheet that I'll pull up on the next slide. And then the second way is just to simply forward us whatever you have. So a few members of this TEP has already done that. So spreadsheets you've had around long COVID, long hauler symptoms, et cetera, just forwarded that to us. And Emma's and Gay have included that in the initial set of symptoms data elements. Okay, so the data element gathering spreadsheet, it's basically 3 tabs. The first tab just provides some instructions and details around how to use the spreadsheet, what the spreadsheet is for. The second tab, which is primarily where we'll focus today, it contains the data elements themselves. a column for who submitted the data element, and then 2 columns around just questions or comments or anything you want to flag for Emma and Gay to consider while they're working through these elements. And then we've also just grouped them by the data element category of symptoms, labs and results, related social issues, etc. And then the 3rd tab for specific for these health concerns is that a list of the symptom assessment scales we're aware of right now, but can definitely walk through those in more depth. So let me just pull up the spreadsheet, and we will make an offline version of this available for everyone to provide feedback on. So I know there are limitations in accessing Google Drive files. So, so there's that. And I will hand this over to Emma now to walk through and review the long COVID symptoms list. But before that, as you can see, here are the categories that we've identified. And then we have the symptoms list in column A. Column C is the submitted by. And then any comments from the TEP to Emma and Gay, and then any questions that Emma and Gay are flagging to the TEP. And then we've got categories that are empty right now because we're looking for your submissions on data elements related to these other categories of data elements. So Emma.
Okay, so hey, hi everybody. Just as far as the symptom list that we have listed right now, this is just the only purpose of this is for us to get started on something. These are really just examples, or, you know, we did a little bit of Google search and we came up with some lists that Google identifies as long COVID symptoms. We want you to give us feedback. We want you to add to the list. If you feel like something's on the list that should not be there, our feelings would not be hurt at all. You can please remove it and let us know that this does not belong there. So it was just really just so we can get started as sort of an example of what we're asking for. So if you feel like anything's on this list that needs to be broken up, or anything's on this list, things on this, you know, we have things that are missing, please add. If things need to be taken out, if things need to be said, you know, like another synonym needs to be used, you know, please, those are all some of the feedback that we're looking for, or we're trying to generate, or we're trying to get you guys to provide for us. A good example.
Can I ask a question on this now? Is this something that the patient's going to be filling out, these data elements somehow? And is a patient filling this out, or is a physician or some other provider filling it out?
And that's what we need feedback on. So you as caregivers, or patients or providers, do you give the patients forms for them to fill out this, like list the symptoms that they're having? You know, so that's what we're actually asking you to let us know.
Well, for me, I do, because we use patient-reported outcomes, so the patient actually fills it out themselves.
Okay, and that's great.
What I put in for this, the GI symptoms that I put in.
Yes, that's perfect, and that's what we want to know. Like when you ask patients to fill this out, what kind of information do you want them to provide to you? You know, that's the kind of information that we're trying to get from you. If you notice on the list, there are some things that have asterisks next to them. And we did receive, like somebody asked in chat before about assessment scales. We did receive, you know, some assessment scales that is used in this area, which we try to find them and put links to them so that you all can get to look at them and see if these are things that you use. And if there are other ones, we would appreciate it if you share that with us so that we can make sure to capture that as part, you know, of the work as well.
Hi, it's Diana Barron, Survivor Corps. We have a full list of all the symptoms related to long COVID that will help fill this out. A lot of the neurological symptoms are underrepresented here, such as we're seeing a lot of Parkinsonian like tremors, feelings of inner vibrations, not necessarily akathisia, but similar. Extreme neuropathic pain mimicking advanced diabetes.
Yes, and that's what we want. We want you to give us that list.
So we have it. We have the full list.
That's perfect.
And we also have a lot of other things. We have vertigo. We have tinnitus or tinnitus, however you want to pronounce it. A myriad of symptoms that are not represented here. That I think are really important.
Yeah, this is just to get people thinking about the kinds of things that you do provide or that you do use. This list is only meant to get the conversation started. It's not meant to be exhaustive.
Even to the extent, I mean, we're also severe dental issues. Included, people are losing teeth left and right because of vascular damage to the jaw.
Yep.
People are having vision issues. There is literally no specialty that is spared. A lot of dermatological issues. I could go on and on, but we have looked. And by the way, we published a paper probably a year and a half ago, not just listing all the symptoms, but also relating them to the amount of human suffering and pain that they were correlated with, as opposed to looking at what are the most frequently reported symptoms. Brain fog really should be called cognitive dysfunction. Brain fog makes it sound like a hangover.
Yeah. So, and like I say, please, that's what we want. We want responses exactly like how this is how we do it. We need it to be more exhaustive. This is an example of you can provide us that information. We would be very happy to include it.
If someone could just reach out to me after this, and someone just put in the chat about Recover. I'm on the Recover committee. Was there a question about that?
So Karen, was there something in chat about? Okay.
I would not look I would not look to the Recover committee, by the way, the Recover team for their data elements, because their data elements are totally wrong. They are really, really not. It's at least one part of Recover. Yes, it is a big initiative, and it is going in the wrong direction and covering all the wrong things. So
Diana, would you the list that you have, if you could add it to our list, either through the spreadsheet or the alternative method, that would be terrific.
Yeah, if someone could just touch base with me afterwards, and I can get you all the information.
And I'll email you.
Okay,
but
perfect.
I'll also email everyone on the TEP.
I would not look to the Recover project as a model for anything. It's from top to bottom to top, a disaster, and using all of the wrong elements. So that should not be a guide for anybody.
Yeah. And thank you, Diana. We really appreciate that help.
Unfortunately, I wish it were different.
Okay, Karen, there's another question. And hang on.
Yes, Tim. Tim's question is there a question that examines the current landscape of tracking tools, databases, and population registries in place to collect and report out on long COVID?
So to answer, that's the part, the quality reporting aspect. And then we were hoping that some of the downstream use of this data that Evelyn mentioned when she did her overview before, which does include public health and all those kinds of downstream systems. So yes, we want to make sure that our list or our data elements are robust enough for us to be able to support all of those other tools and databases.
Can I just, I think it would be really helpful to have someone from the Mayo Clinic on a call like this, because I met with them last week up in Rochester, Minnesota, and they are light years ahead of the rest of the world on these things.
Sorry.
I mean, they've finished all of the phenotyping. They're done with it already. And that's what the Recover 4-year plan is intended for. I feel like this is very redundant work and duplicative of efforts that have already been made.
Okay, and we can.
There could be more. I think that there could be efficiencies worked in here.
Definitely. So Diana, I'll definitely email you about that and just to make sure we have those bases covered. Also, just a quick reminder to please use the hand raising feature just so we can ensure. No, all good.
I'm going to go help with the movers, I just moved in, so let's be quiet.
Okay, thank you.
So somebody asked if we think these data elements are evidence-based as opposed to what we think. We pray that it is. We do make a reference to the COVID-19 work that was done, data element library that was done as some of, initially when the, COVID-19 first came around. So we also, a lot of the work that we do, we hope, or we try to make it as evidence-based as possible.
Yeah, and just a note on that. I mean, I think, I think we obviously want to include things that are evidence-based, but I think we also want to be open to things that are suspected for inclusion. Just because I think, to the extent that this could help us with future research, there's so much we don't know about COVID and its potential sequelae. So I think that there's, even if the evidence isn't foolproof, I think we want to be open to exploring things where there's, say really good epi evidence suggesting there's an association, but we don't yet understand the mechanism, or vice versa. The epi data might be a little lacking, but the mechanistic data, might be there to suggest a potential connection.
Yeah, I would agree. I think that the mention of the movement disorder is very interesting and important. That's really not appreciated out in the lay public. It's all about supposed brain fog, but there's a lot more going on, it sounds like.
Thank you.
And this is the type of narrative that I think is helpful when submitting data elements. So, we want to just have like considerations for potential research or like down the line too. So that will help Emma and Gay also as they work this into the implementation guide.
Yep, and this is Evelyn. I'll just our lessons learned from the gravity work, that if you do, mainly they start evidence-based, but I appreciate that we are working with data concepts that are very new. So I think is also acknowledging if you're submitting it, often I think some of you already did, but if there is some evidence or something from a project, that you also include it.
That would be really helpful. Thank you. Any other questions before we go on to the next part of this? Okay, so an example, just to give a brief example of when we say, please give us more information, or, for example, the one with rash. Do you want to, do you guys usually in your scope of practice or actually go into detail as to the type of rash? Because rash can be very, it can be a large list of different types of rashes. So those kinds of things, if you do this, give us the list. If you want to go to specific types of rashes, provide those specific types of rashes that you find. That would be extremely helpful to do that. All right.
Shelley has her hand raised. Shelley.
Hi.
Go ahead.
Hi, this is Shelley Spiro, Pharmacy HIT Collaborative. My question is more over on the workflow and the data collection portion. Although I know you're not at that point yet, but I have a burning question on this. So if we look at the workflow of our clinicians who are collecting data, and in the EHR, the problem list is created, are we going to be identifying different codes for long COVID, or are those symptoms that are on the problem list going to be connected to long COVID? I mean, how do you envision that process working as we look at the clinical documentation processes within our EHRs? because that data is being collected today at every encounter, but it's not codified as long COVID.
So that's that.
Yeah.
Go ahead. I'm sorry.
You can go first, Emma, and then I'll just add on if
No, I was going to go into the next part of when Shelley brought up coding, but you can go ahead, Jenna, and then we would, because there's more to the spreadsheet.
So I don't think, Shelley, that we want to necessarily speculate to the cause of some of these symptoms. I think we just want to make sure that we are able to record and capture them. You know, I think that I don't know that it makes sense to have, for instance, like a separate, you know, set of pain codes that are specific to COVID pain, unless it turns out that there is like a specific COVID pain syndrome, if that makes sense, right? So I don't think, I think a lot of these symptoms, we just want to be able to track them. And then I think it will be up to, you know, in the context of care planning, the individual caregiver to potentially draw connections between whether the symptoms are associated with COVID or not. And similarly for research. But, you know, I think we can't ask the questions and make the connections if the data aren't there.
Well, maybe this is a parking lot area, because I know you're in the identification of what symptoms we want to, or what we want to identify from a codified aspect for long COVID. But I'm worried that we're going to be either crossing some of the documentations, and I just think we ought to take a look at that workflow process. And if you want to put it on a parking lot and have it as another discussion, I'm fine with that. But I didn't want to lose that thought, because I think it's important that we think about our provider burden and the coding of, or the, you know, capturing of that data within the value sets that are being programmed into the workflow of our clinicians.
Yeah, we do. So we will make an attempt to codify the data. Now you're asking if we're going to codify the data as long COVID, and it all depends on what, you know, the TEP, or what this group define, or what in the literature is defined as long COVID. Have to remember that another attribute, at least if you're using the FHIR resources to collect this information, is also to be able to capture the ability for duration. How long did this symptom last? Does that make it qualify for long COVID? You know, those kinds of questions. Right. And I think this is also research, you know, things that research would take into consideration as well. You know, the person had X symptom, well, how long did they have it for? We know, was it intermittent? Was it consistently? Did they have a consistent duration? Was it present all the time? You know, was it present in, you know, along with something else? You know, those are all research questions that will be, that, you know, that this information, or the data around this can be used downstream.
Okay, thanks. Thanks. And I'm sorry that if I put it in the wrong place, but.
Oh, no. This is, I mean, these are all things that we're gonna, you know, as we go through the profiles and Kay and I, you know, work further on this. This isn't just capturing a list of codes or a list of symptoms and that's it. There's more to it. You know, right now we're just identifying the symptoms, and then we'll start talking about the attributes and things that go with the symptoms.
Yeah, because I'm looking at, you know, what's going to come down the line into registries and into electronic case reporting as we begin to identify the symptoms in relationship to, you know, identifying it as long COVID.
Exactly. And remember, there's a whole query paradigm behind in FHIR, you know, in order for you to be able to get and share the data, to exchange the data. So when you go to do these search parameters, you know, are you searching the code as well as the date, or, you know, in status? You know, those are all search parameters that kind of tie these things together to tell the picture that research needs to know.
Right. Thanks for the clarification.
Thank you. All right. Any other questions? Any other hands up? I can't see you.
No other hands up, but are there any other questions?
I think there was one point that was made about the use of terms that patients will understand. And I hope this is something that the TEP members can help, provide to us. Like in the context of how you say this in your clinical vernacular, do you also take into considerations if you're going to ask patients to supply this information, what the patient vernacular will be? We would love to get that kind of input. All right, so the next thing we wanted to do in this spreadsheet was just kind of show you, because as Evelyn explained in her overview of the data breakdown, a lot of times what we need to do is be able to codify the data. So this is something else that Gay and I will be working on. So yeah, so what we did was we took an initial stab, and I apologize for this because coding can be very gnarly, as to looking at SNOMED and trying to get some sort of, putting some sort of codes behind it. And as you can see, our symptom, and I'm gonna call it category for brain fog, can be broken down into many different pieces or get into more specific things. And this is another thing that when you provide us your list, we will look at the codes and we will give you a list sort of like this. And you tell us if this belongs here or it does not. You know what I'm saying? Like include this or exclude that. That part would be really, really helpful as well. So if you feel like when we talk about brain fog, and I think somebody mentioned that it could be cognitive impairment. Well, SNOMED has impaired cognition with many other children, sort of specific codes towards that. So that's something that you can take a look at, and we will leave it in the spreadsheet if people want to go into more detail and say, go through this and say we would never use that, or yes, that, or they need to, we need more codes, that kind of thing would be very helpful. So we did go through the list and try to put some code, at least for the ones that exist, that our starter list and stuff. But if you really feel like this doesn't belong there, the entire group doesn't belong there, we just let us know that wouldn't be used. For the ones where you do not have children, that's as specific as SNOMED goes. Like, yes, like the diarrhea one, but at least from a symptom or a finding perspective.
Shelley, you have your hand raised again?
Yeah, it might be helpful to have a column, a synonym column. So you could be looking down this list, and as your example of brain fog, you can sort of see where brain fog would fit into some of the cognitive codes or terms.
Okay.
Just as a suggestion, whether you do that or not, up to you.
Yeah.
But
yeah, we can definitely do that. But again, just also remember that within the fire spec, and I keep going back to this because this is where the data will be, how the data will be shared. You can use a code and use the text element to put in the way you say it, as long as it's a synonym. Okay, so even if SNOMED doesn't have the word brain fog, we can put brain fog, because usually I think in the code element of the resource that holds this information, the data type supports it, where you put brain fog in your text, and then you have the place to put the actual code. So if you think brain fog in your thinking means cognitive deficit or disturbance of cognition, you know what I'm saying? You can still keep your brain fog, and we will just use the code that goes, the code pieces that for the code for it that will go into the coding element.
Yeah, Emma, this is Shelley. That goes in, you can submit it to SNOMED International as an actual synonym to that code. But then I know that sits behind the scenes. But I think for this group, as they're identifying some of these areas, I think they could help us sort of make those connections on the synonyms so that we're not duplicating a lot of the work and the terms.
Yeah, we can certainly add another column. We actually had a column. We're trying to make the list, the spreadsheet a little less complicated, but we can certainly put back in the synonym column. Thanks for that suggestion, Shelley. Any questions?
This is Jerry. I wanted to make a comment, or maybe two comments. The first is that I think everybody needs to be clear on the fact that they're going to be given the list, the data element name list already. They're going to be asked to add to it if there are any other categories. But then they're also being asked, if they can, to go to the coded data elements and look at those and comment on those if they can. And they would comment on, and then that, I guess, the fourth column. And the question about synonyms, I mean, in part, I think it's perfectly reasonable for people to go, this particular one duplicates these others. I don't really think they're different. That could be useful information. Yeah. And that might take care of some of the synonym problem, because there is a lot of, there's some ambiguity there, and there's some like impaired environmental interpretation syndrome. I frankly don't know what that is.
Yeah, you can take it off.
So yeah, my suggestion is going to be, I've never heard of that. Tell me what it is, or let's not use it. Anyway, that's just my comment.
And that's exactly what we need you to do. And now, I will say this list was, when you look at SNOMED, there are a lot more things there. We did take some things off that we didn't think, like cognitive deficit related to a stroke or something like that. So those are some of the things that we did take off that we thought maybe would not be related to long COVID at all. So we did clean up the list a little bit. But if we definitely want your input if we need to do more cleaning up of the list.
And I know we've been mostly focused on symptoms, but in the broad bucket of like the component of health concerns, the broad umbrella, we are also looking for data elements. So Emma's only put in one, but this is any labs, radiology, et cetera. So the test and the results, data elements that can go in here. That we're also looking for, related social issues. We're also looking for data elements there, as well as diagnoses. So
any of those would be really helpful if you could help provide some of those. And like I said, don't worry about the coding part. You just provide us what you have. We will look into get it coded. If you have codes, certainly share it. We will appreciate it, just to make sure we hit the specific ones that you need or that you use. That would be extremely helpful as well.
Any questions? Not necessarily related specifically to the specific symptoms, but just any questions about the process of data element collection, which data elements we're looking for in the next 3 weeks.
This is Rachel. I just have a quick question. I was pleased to see the social issues, because that was actually my question, was kind of like how broadly we could go. And are there any guidelines or parameters you could put around the elements that you would be looking for in that section?
I can add a few examples, but, and this was with me thinking, with my nurse hat on, and some of the things that we've come across with patients typically that have chronic issues, chronic conditions, things like job insecurities and those kinds of things, and not, being able to pay for healthcare, not having insurance coverage, and things like that. We can certainly add just to help get people's thinking cap or thinking juices coming.
Yeah, Jenna,
That's great. That's exactly what I was thinking, but I just wanted to make sure I was on the same page as what you were envisioning there.
Yeah, with regard to social issues too, I would think upstream and downstream of COVID as well, in terms of like, I think we would want to think about, job insecurity and joblessness and things like that, that might be a result of having long COVID. But I think it might also be important to think about things that might, from a care planning perspective, interfere with the person's ability to, access healthcare and carry out and follow through on healthcare as well, which, more or less kind of does bring in the whole sort of broad social determinants of health. But, I think especially highlighting things that would be particularly of concern for the long COVID population, I think would be useful.
And this is Evelyn. I'm just thinking too, as we think of all the social determinants of health domains we work on in Gravity, some of them particularly downstream focused, but we also have upstream ones. So I think it might also be helpful for this group of categorizing them, like what type of social issue? Is it a food insecurity, housing, employment status, or, I'm just thinking that these are things that might be important.
I can't figure out how to raise my hand on the screen. I apologize.
Okay, go ahead.
One thing to add is possible suicide ideation. We are getting suicide threats daily at Survivor Corps.
Okay. I think that's a great point, suicidal ideation. And I think that is something we do have on the multiple chronic conditions list too. So
yeah, I
think that
really
is an
feel like
important
there's a tsunami of suicides coming our way, and we need to brace for it.
Oh, that's so sad.
I know, it's horrible. We are literally, like, you have no idea. I spend half of my day talking people off the ledge. I am not trained for this.
Yeah.
And we have members who have killed themselves from long COVID that resulted from asymptomatic cases.
And I thought when I was going to the list that I had every symptom. I didn't put that part in there.
I know. It's tragic. It's really tragic, but it's really real also. In fact, one of the things that Mayo is doing, which I thought was fascinating, is they have there's an app that people can talk into every day for like 15, 20 seconds. And it can be a landline, it can be on the computer, it can be on your cell phone, and it analyzes your voice tone or whatever it is. And it can see when you are depressed enough that you are in risk of in that suicidal zone, and it automatically alerts you, your doctor, and your emergency contact. So there's technology out there that we could be used that is not. I'm working with the heads of a bunch of people there, but specifically Ryan Hurt and Ravi Ganesh are the two heads of the long COVID of the Mayo Post-COVID Care Center. But I'm also on their advisory team. Halamka brought me in to work with Andrew Badley and Claudia Lucanetti. So those are my.
So Diana, we will number of us involved in this will definitely check on Mayo and what it's doing. Thank you for telling us that.
Yeah, they are just light years ahead of everyone. I just actually hooked them up with Akiko Osaki at Yale and with Regeneron. The goal is really to create a specific monoclonal antibody at this point to target long COVID.
All right, thanks, Diana. And
thank you.
Definitely, please provide us some of these thoughts and things that, make sure we have those included.
Yeah, and one of the things that we're trying to do is, because unfortunately Mayo's not investing enough in getting this information out there, we're working to try and take their clinical guidance and make it available to all doctors. And so we have Kavita Patel working with us on that.
Thank you. So in the interest of time, I will just move us along. So the next steps are basically, now that there's just a better understanding of the data elements we're looking for, any attributes, any considerations that you're not sure where it fits, but that we should consider in this work. And feel free to just send that to us. So we'll send around this data element spreadsheet. I think the utility to that is just reacting to the symptoms that we have already initially put together. But in terms of new data elements or any others for the other categories, just send them to us in whatever way is easiest for you. And then Emma and Gay will work to go through that, and we'll bring back to this group any follow-up questions from there. Any questions around these next steps?
I have my hand raised again. I can't.
Oh, yeah, go ahead.
Sorry. Well, I have one question. It might have been covered already. I'm sorry. I've been sort of in and out. But one of the problems that I saw that I'm seeing in the Recover project is how they're limiting the people in their cohort to gather data based on how long it'd been from infection to seeing a doctor. And so really using electronic health records, which is a terrible way, because most people have not been to the doctor for long COVID. There is no doctor for most people, and the waits at the post-COVID care centers are over a year long. You can't get in despite CDC guidance unless you've had a positive PCR test into almost any of them, and GPs have nothing to offer. So the fact that someone has not been to a doctor, if you're only counting people who are seeing physicians within X amount, I mean, I had COVID in March 2020. I didn't see my first doctor until the end of August of 2020. So I wouldn't have, even with a positive PCR test in March 2020, I wouldn't have qualified. And nobody saw a doctor during any of that time. And we were in lockdown, and the doctors didn't have any answers. So I just think that's important that we be really realistic about who are the people who are suffering, and that they are really, most of them are not under any medical care.
Thank you for that feedback. And we will definitely look into that. I believe another TEP member is involved with the Recover work. So, and this is why groups like this panel is so important, is so that we can capture the perspectives from all around. Was somebody trying to speak? Okay. All right. Well, we have 5 minutes remaining, but we'd be happy to end the call here if there are no further questions. But yes, please send us any and all information in whatever format you have that will help inform the data elements for the broad umbrella of health concerns for long COVID. Jenna, Emma, Evelyn, I don't know if anybody has any final words.
I just wanted to thank everybody, and please help us make this work into a success. We really, really do value and appreciate your input. And please also let us know if you have any questions, or if you think something can or cannot be added, just send it. We will reach back out to you if we have any questions or if we need anything specific.
Yep. So just echoing Emma's thanks to everybody for all their input, and thanks in advance for sending in their data elements and adding them to the adding them to the spreadsheet.
All right. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.